The patient will clinically represent. Number first, obviously, clinical signs are inspection. You will inspect whether there are any wasting or fasciculation. What is the tone? It is spastic or can be flaccid. Power is weak. Reflexes the Brex the Babinski or the Brex reflex is absent or not. Absent knee jerk with extensor plantar reflexes. The knee jerk is absent with the external plantar reflexes, and sensory examination is normal. Very important point. If someone asks you the sensory examination in basically multiple motor neuron is normal or not, so basically it is normal. The clinical signs inspection, wasting, and fasciculation. The tone is basically either spastic or flaccid. The power is reduced or weak. Reflexes may or may not present, and sensory examination is normal. Extra points that you should be like diphtheria. Okay, diphtheria may be bulbar or nasal Donald duck speech due to the palatal weakness, or pseudobulbar hot potato speech due to the spastic tongue. Means the patient will have the dysarthria, maybe the bulbar nasal dollard duck speech, or due to palatal weakness, or pseudobulbar, which is actually a hot potato speech due to spastic tongue. The tongue wasting and fasciculation or stiffness of a spastic tongue with a brisk jaw jerk, pseudobulbar, and difficulty in swallowing. So you will check for either there is how is the speech, either is a dollar duck or a pseudobulbar like a hot potato speech due to spastic tongue is tied. So that's why tongue wasting is present or not, fasciculation is present or not, stiff spastic tongue with the brisk jaw jerk and difficulty in swallowing. There are no sensory extraocular muscles or cerebral extrapyramidal movements. Sphincter and cognitive disturbance are occasionally seen. For this, we'll see the whether the muscle wasting is present or not. See the face. Now, basically, how you diagnose? It is basically on clinical diagnosis. In clinical diagnosis, you actually see you basically see either any fasciculation is present or not, how is the tone, what is the power, reflexes are present or not, how the sensory senses are working or not. In MAG you will see fasciculation. AMG is basically electromyography and you see fasciculation. In MRI you see the brain and spine, that excludes the main differential diagnosis for the cerebral cord compression and myelopathy of the and brainstem lesions. Okay, so basically what is the treatment? The treatment is supportive, which you will give a PEG feeding and NIPPV multidisciplinary approach to care, the reluzole, which is glutamate antagonist. Slow disease progression may by an average 3 months, but does not improve function or quality of life or is cost. Means you will give a multidisciplinary approach. You will give a glutamate antagonist, basically, which is reluzole. Okay, the disease can be slow by average of the 3 months, but it does not improve. Okay, now prognosis, most die within 3 hours of diagnosis from the bronchopneumonia or respiratory failure, or some disease variants may survive longer. Worse if elderly onset female with bulbar involvement. They are saying if the female is involved and the patient is aged, so it basically have a worse prognosis. Okay, now another they have also tell you about the bulbar, basically bulbar involvement actually. Now the bulbar involvement is basically something related to the especially medulla oblongata, the lower part of the brain stem. Okay,